sabotage. So the thing which you see on fluorescein angiography are hot discs here, you know. And it is a granulomatous uveitis. And this is a typical case of Fuchs uveitis, which in 100% of cases, well, you cannot say 100%, 99% of cases is showing a disc hyperfluorescence. Now, fluorescein angiography gives you information on the superficial structures as well as the RPE. And there are only two conditions where it is sufficient for the follow-up. This is Behçet's uveitis and intermediate uveitis of the pulmononitis type. In most other conditions, you need indocyanine green angiography to make a complete workup. So this is dating back to the middle 90s, and there were some doubts about it, you know, but there are no doubts to use ICGA in uveitis. Fortunately, this dye is used very extensively in surgery, and that's why we now have enough quantity of ICGE available in ophthalmology. This is a patient that presents an explosive choroidal inflammation that has spilled over into the retina, as you can see here and here, with exudation here, exudative serous detachment, and of course the diagnosis here is VKH disease. After initial treatment with prednisone, cyclosporin, and mycophenolate, the situation is under control. But the patient still complains of headaches. So is the situation really under control? Would you step up with treatment? Let's see what EDI-OCT tells us. Well, it's a little bit thickened, but acceptable, as you can see here. So let's see what ICGA is showing us. Diffuse choroiditis in the periphery. So based on these alarming ICGA signs, we decide to add a anti-TNF-alpha agent going to quadruple therapy. And look what's happening after only, how many weeks? 6 weeks. You know, we go from here to here in the right eye, and from here to here in the left eye. There is a spectacular improvement. And the headaches disappeared. So, without ICGA, ongoing choroidal inflammation would never have been detected. Moreover, determination of the therapy that was active in this case, anti-TNF-alpha, would never have been possible so quickly. So ICGA is an exquisite biomarker for choroidal inflammation, essential for diagnosis and monitoring of stromal choroiditis. And this is how you can follow your patients using ICG. You can see here that fluorescein angiography doesn't tell you much. EDI-OCT doesn't tell you much. But if you are following ICG, you can see that there are subclinical recurrences here which otherwise you would not have detected. The choroid is hidden behind the RPE, which stops all visible light. Two main structures make up the choroid, and inflammation can occur in either of them, the choriocapillaris and the choroidal stroma. This is telling you that fluorescein angiography is not useful to analyze the choroid because of the RPE. ICG is fluorescing in the ultraviolet range, and be careful, don't call this a cyanescence. This is not a cyanescence. Somebody invented this term, and then, as usual in medicine, everybody is going and telling the same thing. This is a fluorescence, but it's a different fluorescence than in fluorescein angiography. So what happens with ICG? It doesn't go out of retinal vessels, but it goes out from choriocapillaris and fills in the choroid here. And if you have a lesion here, the lesion will come out negatively dark on ICG. There are two patterns of ICG frames. Choroidal stromal disease, as it is the case in birdshot or BKH. In birdshot, the granuloma is a partial thickness. So you will have hypofluorescent dots in the intermediate phase, which become isofluorescent in the late phase. BKH is full thickness lesion, and it will remain hypofluorescent in the late phase also. So what information do you get for the choroidal stroma? It is what we started to call a few years ago the iceberg effect. So the iceberg, can be very dangerous. As you can see here, the Titanic sank because of an iceberg. So in ophthalmology, in uveitis, we have what we call the choroidal iceberg here. Nothing can be seen on the fluorescein angiography. The lesions are very well identified on ICG. So these are the different types of stromal choroiditis. Now, if we sum up the signs which you are looking for on ICG, number one, the sign which is well known from everybody is the hyperfluorescent dark dots. But this is not only what you're looking for. You're looking for fuzziness of choroidal vessels, choroidal vasculitis. And you can see here that you cannot recognize the choroidal circulation here in active disease. Once you treat it, you can see again very well the pattern of choroidal circulation. Other signs in ICG angiography, usually the disc is hypofluorescent. In very severe inflammation of the choroidal stroma, you will have a hyperfluorescent disc. And again here, you can see that the vessels are completely fuzzy. After 3 days of 1 gram of prednisone per day, you have already this achievement, and you can again recognize the vessels of the choroid. Now, the question is ICGA still relevant for uveitis? Yes, for diagnosis and for precise follow-up. It can be illustrated, complemented by non-invasive methods, but at the base, you should do fluorescein and ICG angiography to have global information. This is a case of, everybody recognizes it, this is a case of birdshot retinochoroiditis. And what is this case here? Birdshot retinochoroiditis. But you can't tell by looking at the fundus. What is giving you the answer is both the fluorescein angiography here, showing the vasculitis, which is unrecognized in birdshot so far, We just published 2 articles on this aspect of birdshot retinochoroiditis. But what is very useful is indocyanine green angiography, showing a subclinical choroiditis which is not yet visible on fundus photography. Of course, this case was HLA-A29 positive. What is the rate of positivity of HLA-A29 in birdshot? It is not 95%, it is not 96%, it is not 98%, it is not 99%, it is 99.9%. In medicine, you can never say 100%. Early diagnosis, thanks to ICGA, is crucial in birdshot because early and sustained therapy changes the phenotype of birdshot HLA-A29 uveitis. This is how the disease should be called. Birdshot lesions never appear if you treat it early. So what is the pattern for choricapillaritis now? This is the second type of information which you will get from your ICG angiography. This is choricapillaris non-perfusion. As you can see here, there is an area of non-perfusion due to inflammatory non-perfusion of these small vessels. And they appear dark, geographically dark on ICG. This is the case of APMPPE. Now, what happens in choricapillaritis is that it behaves like a jellyfish, you know. As for jellyfish, lingering unseen immediately under the surface of the water, the danger in inflammatory choricapillariopathies is also immediately under the RPE at the level of the choricapillaris. Now, you have to use ICG to correctly assess the extension of lesions and correctly follow up these lesions. These are the different types of choricapillaritis. We will have a talk later on the topic. Now, there are 2 types of choricapillaritis. And listen very well, because this is very new. There is the end choricapillary non-perfusion, which you have in mudes or mild cases of multifocal choroiditis. And there is a normal or normal-sized non-perfusion of the choricapillaris, which you have in diseases like APMPPE. Depending on the vessel which is touched, you will have different types of choricapillaritis. This is a typical case of multifocal choroiditis, and you can see again that you need ICG for the follow-up, because on the fluorescein angiography, nothing changes from presentation to treatment. However, you see that on the ICG, you can see that the recent lesions disappear, and this is followed also by fluorescein angiography. So the multifocal choroiditis responds very well to aggressive dual or triple immunosuppression. And you can follow this very well by ICGA or by fundus autofluorescence, which in mudes is quasi as useful as ICGA. So, following the angiographic explanation just given, it is obvious that these entities cannot be classified together under the term of white dot syndromes, which was proposed by one opinion leader in 1995 and accepted at once by the uveitis community at large. These authors analyzed the histopathology of some white dots from sympathetic ophthalmic VKH and sarcoidosis and said that the granuloma is at the origin of all these diseases. The granuloma is not at the origin of choricapillaritis. So you should not use anymore the term of white dot syndromes, which is a nonsense. Now, we pointed out this nonsense in 2000, when was it, Pier Giorgio? In 2002, huh? Yeah. And I can announce you that since July 2024, you can have a new textbook which is completely white dot syndrome free. Unfortunately, it is quasi impossible to eliminate such misnomers once they are in the literature. So is it still relevant? We can, thanks to a scoring system, determine which part of the fundus is more inflamed than the other. And we published this system back in 2010. Here you have a fluorescein score of 19. I don't go into the details. Here you have an ICGI score of 20. Now, if you look at a disease such as sarcoidosis, you will see that the retina is less involved in quantity than the choroid. Similarly, the proportion of cases with preponderant choroidal involvement are much larger, something like 70% in sarcoidosis. And the same is the case in tuberculous stromal choroiditis. So this is why you need ICGA if you want to have global information. Now, this is a case of unilateral choroiditis which spilled over into the retina, as you can see here. And here, everything seems normal. There is inflammation on the right eye by laser flare photometry. So we were interested to look what happens in the choroid. And you can see that this is a bilateral choroiditis. And indeed, this was VKH disease. Which was occult on one side. There is no such thing as a unilateral VKH. It is just, these are just cases that were not investigated for the choroid. Another example among many, this is a patient that came to us from another city in Switzerland, and the doctor there wanted to give her corticosteroids because of the inflammation of the optic disc here. She seeks a second opinion, and what we see here is a extended choroiditis on both sides. So we need to know what is the diagnosis, and the quantiferon was positive, and the disease responded to anti-tuberculous treatment only without corticosteroids. However, you should be careful to avoid the hypersensitivity reaction if you give only anti-tuberculous treatment. This is a case who came for neovascular, choroidal neovascular vessels, and when we performed the ICGA, this was a case of MUDs, inflammatory choroidal neovessels. Okay. Yeah, this is another case, but a birdshot, which responded only 5 weeks after the correct treatment. And this is how you can follow your patients with different methods. I think we don't need a conclusion here. The presentation was evident in itself. And we will see now that you can do better than that. You can, have complementary investigations. And these investigations will be talked about by my co-chair and a very good friend, Pier Giorgio. Thank you very much.
So I want to disclose the